We are now going to next presentation by Dr. Anupam Anand from NRS Medical College. Anupam, please restrict your presentation to 6 minutes. Okay.
Very good afternoon, respected teachers and my dear colleagues. I am going to present a case on carcinoma bladder, invasive carcinoma bladder. So this is a 56-year-old male patient, farmer by occupation and a known smoker since last 15 years, who presented with complaints of gross hematuria. On evaluation, CP cystopan endoscopy showed large bladder SOL, papillary, involving left posterior lateral wall and left anterior wall. Left ureteric orifice was not seen separately. On CT urography, bladder SOL was of 4 into 3.5 centimeter in left lateral wall. However, at that point there was no hydroureteronephrosis. Patient underwent TURBT. Histopath was suggestive of invasive high-grade urothelial carcinoma, PT1NX. Deep muscle was free. So patient underwent again restage TURBT. Restage TURBT again showed the same result, high-grade PT1NX-MX. So patient was started on intravesical BCG therapy. But due to some shortage of BCG medications at our institute and also due to some non-compliance from the patient, the whole BCG course became a bit irregular, and he completed second maintenance in a span of about 12 months. So we were following the patient based on cystopan endoscopy during this BCG therapy. On follow-up, after the second maintenance, it showed erythematous, CP showed erythematous mucosa seen at the supposed left ureteric orifice region. However, left ureteric orifice could not be seen conspicuously. Rest of the bladder and prostatic urethra were normal. At that time, we did a CCT whole abdomen and pelvis, which showed a asymmetrical wall thickening in left lateral wall of urinary bladder with extension into lower third of left ureter with left hydroureteronephrosis. As seen in the picture, it had gone and extended from the VUJ. Instead of coming inside the bladder, it has gone and the growth happened in the ureter. So patient was offered immediate radical cystectomy with left RNU, but he refused, citing financial constraints. So patient underwent left radical nephrouretectomy. The histopath is awaited. So in such a case, sir, this is for the opinion from the learned people. So in such a case where the BCG has been irregular, though the patient is T1 but high grade involving the VUJ, large tumor involving the VUJ T1 high grade with irregular, because it's a very common problem. This is a representative case. We have many more patients like this who have been irregular on BCG, but the recurrence, we are seeing high chances of recurrence. So is immediate radical cystectomy should be planned, or we should, since here the growth was into the ureter, so should we, like in the guidelines it says that the CT should be done yearly. But since the patient is here irregular on BCG therapy, so should we increase the frequency of CCT during the follow-up?
No, upfront cystectomy is always an option. Because you are a high grade, T1 high grade.
Yes, sir.
So there is the literature is there, you can go for upfront surgery.
But in this case, sir, patient actually refused.
Patient refused. So
yes,
there is the other option is that you can go for gemcitabine cisplatin upfront.
Gemcitabine cisplatin.
Sir, what is sir?
What is the trimodal therapy?
So in trimodal therapy we give we do radical TURBT, and then we give chemotherapy and radiotherapy.
Is it possible in this case?
In this case, yes, sir.
No, it is the uterine growth. How is it possible?
In this case, it's not possible because there is ureteric growth, sir. There was about 4 centimeter extension of the growth into the left ureter, sir, from the uterus.
So this is a bladder tumor extended into the ureter.
Into the ureter. But during the follow-up, sir, we were doing the cystoscopy 3 monthly.
But there was a hydronephrosis.
Yes, sir, but we were following up with cystoscopy, sir, during the BCG therapy.
So if there is hydronephrosis, almost it is taken as it is invasive.
In the initial CCT, there was no hydroureteronephrosis, sir.
But I could see the...
In the later, sir, this is after we have seen the suspicious lesion in the CP. First we did a CP.
In this situation, I am telling you,
yes, sir.
if there is hydronephrosis, it is almost taken, almost.
Yes, sir.
Taken that, so high grade T1 that Dr. Chaudhary has told, high grade T1 with hydronephrosis, I think upfront nephrectomy, say radical cystectomy
Systemic
with.
plus left RNU.
You want to say that you have found, you have missed it in the CP.
Yes, sir.
During CP, what are the things you will look for in a case of
Sir, this,
NMIBC?
sir, since this was a case involving the left VUJ, first I will screen all the area of a cystopan, 10 areas of the cystopan endoscopy, and then the ureteric orifice also. I will look for the ureteric orifice during the cystopan endoscopy.
Okay, thank you.
What else?
A prostatic urethra, sir.
No, you see the left ureteric orifice, you will wait for the,
Urine to come.
yes, how it is coming. It cannot, at least we are last.
Invasive bladder tumor? Invasive bladder tumor involving the.
Yes, it is definitely the invasive bladder tumor. Somehow, yes, maybe missed.
তোমার কি আরো প্রেজেন্টেশন আছে?
Okay.
থ্যাংক ইউ, থ্যাংক ইউ অনুপম। সো